A hazardous material, HazMat incident, generally occurs accidentally. However, a chemical, biological, radiological, nuclear and explosives event is likely to be a criminal or malicious act, including terrorism. Any HazMat or CBRNE incident requires rapid recognition combined with prompt and appropriate action. This will facilitate the best possible outcome for contaminated patients and provides a robust firewall to protect staff, patients, and the hospital or facility, supporting continued service delivery. Although infrequent, the impact of these types of events can be significant, creating substantial risk to responders and the clinical environment. Data provided by the UK Health Security Agency up to 2021 for England highlighted a total of 815 acute HazMat incidents. These include swimming pool incidents, incidents in agricultural settings, white powder incidents, and intentional chemical exposure. The first indication that an incident has occurred or is ongoing is likely to be the unannounced arrival of contaminated members of the public presenting themselves to the emergency department, walk-in centres, or other NHS facilities. These self-presenters and those that escort them are likely to provide valuable information about the incident, including the potential for further casualties that may follow. An alert from the ambulance service may also be received. However, there is an expectation that contaminated members of the public, transported from scene by the ambulance service, should have been effectively decontaminated and therefore deemed safe to enter the hospital or facility. Key to successfully containing contaminated casualties and ensuring an effective response is early recognition. No amount of training or equipment is effective unless the incident is recognised. This will prevent any cross-contamination within the facility, protecting patients, visitors, and staff themselves. It is essential that recognition commences at the point of first contact, which requires other NHS staff, including reception teams, to undertake some recognition training. Steps 1, 2, 3+ has been the historic, generic, multi-agency approach to identifying and managing contaminated casualties. This approach has been revised by the Northern Care Alliance to enhance early recognition and rapid containment by applying the NCA Index of Suspicion (IOS) model.
Whilst the patients are being dealt with, the incident would have been escalated within the emergency department, urgent care centre or GP surgery. Specialist advice would have been sought by the clinical teams and tactical support regarding how to manage the patients once they are deemed to be decontaminated and clean. Business continuity plans would have been activated, and if staff apply the contain, assess, respond principles, this will allow the department to continue their routine activity via compartmentalisation and separation of clean and dirty areas. Urgent care centres, GP surgeries and other primary care providers will not, usually, have access to decontamination units and specialist PPE. In this instance, staff working in these areas will need to call the ambulance service, who will respond as required with specialist assets. Whilst treating a contaminated patient, urgent care staff and other primary care services carrying out the dynamic risk assessment must continually weigh up the risk to patients and staff versus the risk of waiting for specialist assistance from the ambulance service.
Using absorbent material, such as blue roll, should be initiated by the first strike officer or responder whilst undertaking the initial assessment and where the contaminant is a non-caustic material. Casualties should be directed to disrobe as quickly as possible, blow their nose and spit out, blot their hair and exposed skin, starting from the top and working downwards, placing any contaminated material immediately into the appropriate waste bags.
Walk towards me. To take the blue roll, you're going to blot the top of your head moving back and into the bin. Right, well done. Fresh blue roll.
I'm feeling really poorly.
Okay, dab down your front, let's get this stuff off you. One arm. Well done. Next, blue roll. Well done. Blot as you go down, never go back up. Keep blotting.
In the event of the first strike assessment, identifying the patient as contaminated with caustic material, or the contaminant is known to be radioactive or biological in nature, then the decontamination method of choice must be wet, utilising the rinse, wipe, rinse method. Rudimentary trials have demonstrated decontamination efficacy is enhanced when dry decontamination is followed by the 3-minute rinse, wipe, rinse, wet decontamination. Real-world incidents have also demonstrated to us that patients report not feeling totally clean unless they shower after dry blotting. Therefore, dry decontamination should be followed by 3 minutes rinse, wipe, rinse where possible. After decontamination, patients can be re-triaged and treated as normal.
By the very nature of NHS facilities being open to the general public and having the NHS logo above them, people will gravitate to these facilities in the event of a large incident. It will be difficult to contain people at the scene, and they will leave that area seeking help at any facility that is close to where they live or work, or where they've been treated previously. In smaller incidents, where an individual or small group of patients are ambulance, A supervisory approach to patient decontamination can be utilised if the dynamic risk assessment demonstrates the risk of cross-contamination is low. The use of standard PPE precautions may be considered appropriate if a safe responder to casualty distance is maintained. The selection of the PPE will always be dependent on the index of suspicion triggers. For example, where a biological agent release or high-consequence infectious disease is suspected, the response will require the organisation's appropriate high-level PPE ensemble. Where radiological or nuclear contamination is indicated, this will require enhanced standard precautions or Tyvek-type coveralls inclusive of an FFP3 mask. It is imperative that responders maintain their regular fit testing in line with the organisation's governance arrangements. However, if the contaminant is unknown, patients are symptomatic, unwell, or the patient requires close personal support and the risk of cross-contamination is deemed to be high, then PRPS PPE must be used. Where an incident warrants the use of PRPS, it is vital a safe system of work is applied, requiring a safety officer to oversee the activity.
If previously ambulance casualties collapsed during the decontamination process, emergency rescue procedures, comprising of further ED staff in PRPS PPE, must be activated. And where this occurs in a non-acute environment, specialist assistance must be requested urgently from the local ambulance service. To respond safely to a collapsed casualty, clear communication is essential to ensure the process is carried out correctly and safely. Patient flow into the decontamination unit or area must be maintained whilst continually monitoring the collapsed patient. Once emergency rescue procedure and decontamination is complete, the collapsed patient can be considered clean and treated as normal, observing for any potential off-gassing that might be a risk to clinical staff delivering ongoing clinical care.
Considerations to support incident recovery should be noted as the incident progresses, with clear objectives set and shared to facilitate a return of the emergency assets to a state of readiness as soon as possible. It is essential the designated safety officer continues oversight of all elements of restoration. A dynamic risk assessment of each element and stage will need to be considered to facilitate the level of PPE required to implement waste removal from the decontamination unit. It is recommended that waste, which includes wiping aids, bad clothes, etc., is stored alongside the wastewater collection system to reduce the risk of spreading any contaminant and creating a single point of collection for the specialist waste removal providers. The second phase focuses on cleaning the decontamination unit. Guidance will be sought from the UK Health Security Agency regarding the appropriate method and cleaning agent required. If PRPS has been utilised, responders must follow the PRPS buddy decontamination procedure to ensure the systems can be bagged, boxed and returned to the providers for recertification. Any contaminated water must be retained and secured in the appropriate decontamination unit's wastewater collection bladders, with arrangements made for specialist wastewater provider collection, either via the Trust Waste Manager or activation of any pre-arranged contract with the ambulance service. It is imperative that all sundry items and specialist equipment, including PRPS, is replaced as quickly as possible from emergency reserve stock. This action will maintain HazMat and CBRNE systems in a state of readiness and mitigate any potential late presentations from the original incident. Although this type of incident does not occur frequently, it is important to be clear that regular and robust training of all emergency department staff is necessary to maintain the skill sets needed to safely respond and ensure ED and hospital business continuity. The responsibility of maintaining training lies both with the organisation and their responders. Therefore, good governance should support and maintain the delivery of your HazMat and CBRN training. Following the incident, debriefing is essential to apply any learning and support a review of your HazMat and CBRN plan in line with your organisation's incident management policy. If in doubt, please contact your department, HazMat CBRN lead, departmental manager or your EPRI unit.